Welcome to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai, where I'm the Chief of Pediatric Cardiology. Thank you for joining me for this 284th episode of the podcast. I hope all enjoyed last week's episode on the topic of sudden cardiac arrest in children. For those of you with an interest in this important topic, I'd recommend you take a listen to last week's episode. As I say most weeks, if you'd like to get in touch with me, it's easy to remember my email. It's pediheart@gmail.com. And please, if you have a moment, please leave a positive review at Apple Podcasts, which helps with the visibility of this podcast. Thank you so much. This week, we're moving on to the world of cardiovascular surgery. The title of the work we'll be reviewing is Contemporary Applications and Outcomes of Pulmonary Artery Banding, an analysis of the Society of Thoracic Surgeons Congenital Heart Surgery database. The first author of this work is Paul Devlin, and the senior author is Tara Karamlou. And this work comes from the Society for Thoracic Surgeons. And the first author, Dr. Devlin, who's also the corresponding author, comes to us from the Division of Cardiac Surgery at Northwestern Medicine in Chicago, Illinois. When we're done reviewing this paper, the senior author of this work, Dr. Tara Karamlou, has kindly agreed to speak with us about it. Therefore, let's move on to this article and then a conversation with its author. This week we review outcomes of the lowly pulmonary artery band, an old operation that first debuted in 1952 as a palliation in an era before intracardiac repair of congenital heart disease was technically feasible. Today, the authors begin by explaining that it is the 10th most common congenital heart procedure, and amongst newborns, the 7th most common. It's also associated with one of the highest mortality rates, and it is this known high associated mortality that the STS used in labeling it as a mortality category Stat 4 procedure, denoting a high-risk procedure for death. The authors explain that there are different indications for banding, and also how some patients, typically single ventricle patients, may need bilateral banding, whereas most require main pulmonary artery banding. They then explain that mostly this study will focus on main pulmonary artery banding and state, quote, "We sought to analyze the STS database assessing the contemporary use of pulmonary artery banding, focusing primarily on patients with main pulmonary artery banding, and how differences in patient diagnosis, main pulmonary artery banding timing, and center factors are associated with discharge mortality. We also aim to determine the variation in main pulmonary artery banding use across STS centers." The authors review that this is an STS database study, and we have of course reviewed many of these studies previously and what the STS database is, but I will remind that more than 90% of all congenital heart disease surgical cases in the United States are captured in this very large database, and the study period for this work was 4 years, from January 2016 to December 2019. The authors review how they identified the pulmonary artery band patients for this work and explain that ultimately they identified 3,367 patients who had a pulmonary artery band in the time period of this study, which represented 3% of the 114,672 total surgical cases of the time period. And they explain that 80% of these bands were an MPA band and 20% bilateral pulmonary bands. For this work, the primary outcome was operative mortality, defined as death before hospital discharge or 30 days after pulmonary artery band procedure, whichever was longer, and the secondary outcome was postoperative length of stay. Tons of data regarding patient characteristics, surgical characteristics, and more were recorded for analysis. And on to the results! Operative mortality in this time period for all MPA band patients was 8%, and was lower than those undergoing bilateral PA bands, where the mortality was 26%, likely reflecting the fact that most of the bilateral PA band patients had complex heart disease like hypoplastic left heart syndrome, and the authors have a great table, Table 1, showing that 60% of the bilateral PA band patients had HLHS, followed by 5% single ventricle with an unbalanced AV canal defect, 4% with an interrupted arch and VSD, 3% Schoen syndrome, 3% with single ventricle and mitral atresia, complete AV canal in 3%, and valvular aortic stenosis in 3%. Also shown in this chart is the breakdown of diagnoses of MPA banding, and the most common is the complete AV canal, representing 19% of the MPA band cases, followed by VSD with arch obstruction in 17%, then double outlet right ventricle in 15%, isolated VSD in 14%, and triatresia in 10%. The authors demonstrate that triatresia and double inlet left ventricle were the most common single ventricle lesions in which an MPA band was used. The investigators then review the operative mortality of MPA banding and demonstrate real differences in mortality rates. For diagnoses that exceeded 10% of the cohort, the lowest risk pulmonary artery band was in patients with triatresia, where the mortality was 3%, and the highest mortality was in those with complete AV canal, in which the mortality rate was 13%. And again, Figure 1 shows the mortality in the MPA bands by diagnosis. When looking at the MPA banding procedures, the authors explain that 29% were isolated procedures in which the MPA banding was the only procedure performed, but in the majority, or 71%, the MPA banding was performed with something else, and Table 3 has these other procedures. But to just review the procedures that are triple digits in terms of numbers, there were, in descending order of frequency, and again, these are things that were done at the same time as the MPA banding: PDA closure, then aortic arch repair, creation or enlargement of an ASD, some other unlabeled cardiac procedure, bidirectional cavopulmonary anastomosis, and coarctation repair. Once more, I'd recommend you read the paper for these small details. Because of the other procedures performed, cardiopulmonary bypass was used in 36% of these procedures in which an MPA band was placed. Importantly, 192 patients who had a main pulmonary artery band placed, which would be 7% of the MPA band procedures, required a PA band adjustment procedure, with 86% of these patients having just one adjustment, but 12% needed two, and 2%, or 4 patients, needed 3 band adjustments. If one needed an adjustment, there was a substantially higher mortality of 16%, versus initial MPA band mortality of 8%. The authors comment on center variability of using this procedure, but explain that despite substantial center-to-center variability, mortality was not higher in lower PA band volume centers. They then review the impact of additional procedures on outcomes and show that there were major differences in mortality related to when other procedures were done related to the PA band. 66% of patients only had a PA band and had a low mortality rate of 3%. However, if a patient had first an MPA band with a separate subsequent procedure performed during the same hospitalization, mortality was 15%. Amongst all PA band cases, if a patient had a PA band following another separate cardiac surgical procedure during the same admission, mortality was highest of all MPA band patients at 24%. And the most common scenario for this was ECMO followed by a band. Of the 75 patients who had ECMO prior to a band, 61% died within 30 days from the band procedure. The authors also looked separately at those patients who had an LV banded in the setting of congenitally corrected transposition, as well as those who had dilated cardiomyopathy, and there were 143 such cases, representing about 5% of the cohort. The median age at banding in this subset was 257 days, far older than the other patients, and 2% of these patients died prior to hospital discharge or 30 days after PA band procedure, suggesting low mortality rates when bands are used in this setting. In the discussion, the authors review the history of the band, and they review indications for banding, such as bridging to complete repair and complete AV canal, or a large VSD, with or without aortic obstruction, or even in truncus arteriosus. For single ventricular disease, restricting pulmonary blood flow, such as in tricuspid atresia or double inlet left ventricle, can be used as part of single ventricle palliation. Finally, as just mentioned a moment ago, it can also be used to retrain an LV in congenitally corrected transposition. The authors comment briefly on the use of the PA band for patients with dilated cardiomyopathy and how it is theorized to improve ventricular-ventricular interactions, and certainly this might be something we'll speak with Dr. Karamlou about in a moment. They re-emphasize how patients requiring bilateral PA bands are really a very different substrate with much higher mortality compared to MPA bands, 26% mortality versus 8% for MPA band. They re-emphasize that the 5 most common diagnoses for PA banding were complete AV canal, VSD with arch obstruction, double outlet right ventricle, isolated VSD and tricuspid atresia, and how these represent more than 75% of all MPA bands in this cohort. The investigators review again how patients who had ECMO prior to PA banding generally did very poorly, but they're not sure if the band is the reason for it, given that most patients needing ECMO by definition are very sick, though it does suggest that perhaps PA band as a means of rescue in that setting may be ill-advised. The investigators also re-emphasize how these patients who had only a PA band generally had lower operative mortality, and they wonder if future iterations of the stat categories of the STS should take this into account when assigning a stat category to this, and wonder if the baseline disease of the patient should factor into the assignation of risk. For example, single ventricles getting banded generally had low mortality, but AV canal defect patients did very poorly with high mortality. In regards to study limitations, the authors speak about miscoding of procedures with some missed examples, lack of complete clinical data, and a lack of longitudinal follow-up. And so they conclude, quote, "Pulmonary artery band is a frequently used congenital cardiac procedure with high mortality and variation in use across centers. Outcomes vary widely by banding type and patient diagnosis. Main pulmonary artery band after an initial cardiac procedure, especially ECMO, is associated with very high operative mortality." Well, this is certainly an important work. First, it reconfirms the general notion that PA bands are not without risk and deserve a high stat score. However, the level of analysis of this work has clearly shown us that some PA band patients should be expected to do better than others, on average, and it does indeed seem to me that a reconsideration of this procedure and the assignation of risk by the STS should be pursued. After all, some cases clearly are lower risk than thought, but then again, some are actually very high and maybe even deserve a higher stat designation, perhaps stat 5. There are some things to unpack here, and so in the interest of time, I think we should move forward with our conversation with the work's senior author, Dr. Tara Karamlou. Dr. Karamlou is a pediatric and congenital heart surgeon in the Department of Thoracic and Cardiovascular Surgery at the Cleveland Clinic Children's Hospital. Dr. Karamlou earned her medical degree with high honors from Baylor College of Medicine in Houston. She performed her residency at Oregon Health and Science University in Portland, Oregon. Dr. Karamlou performed a research fellowship from the Thoracic Surgery Foundation for Research and Education, and also was appointed as the Congenital Heart Surgeon Society John Kirkland David Ashburn Fellow. This 2-year non-clinical appointment focused on outcomes research within the CHSS Data Center, located at the Hospital for Sick Children in Toronto. As part of this fellowship, Dr. Karamlou earned a master's degree in biostatistics from the University of Toronto. It is a delight to have her back on the podcast. Those podcast listeners may well recall that she was a guest on the podcast back in July of 2022 on the topic of socioeconomic and racial disparities in congenital heart surgery. It is a pleasure to have her back. Welcome, Dr. Karamlou. All right, I'm here now with Dr. Tara Karamlou, back for a second visit to the podcast. Dr. Karamlou, thank you so much for joining us this week on the podcast.
Well, thank you, Robert. It's really great to be back, and I'm really looking forward to our conversation today. For those of you who don't know me, I'm a pediatric heart surgeon at the Cleveland Clinic, and I am also a surgeon scientist. So I think we're going to talk about some science today.
Absolutely, and no one better to come to for this kinds of questions than you, so we're very excited to have you. Thank you very, very much. So, Dr. Karamlou, very interesting paper. For those of you listening today, Dr. Karamlou had a brief conversation talking about our biases about this operation, the PA band. One of the things that I noticed in your study was that the need for ECMO followed by a band was really bad. It was a very bad association. And in generally speaking, I think of all the different people who got bands, I think it'd be fair to say that in your work, if you had ECMO and then you were using a band to sort of get out of trouble later, those patients had probably the worst outcomes in your group. And I'm wondering, is it just that ECMO, by definition, do you think is just identifying really sick people who are a high-risk cohort who are just, in general, more likely to die? Or do you think that there may be something else at play?
Yeah, I think, Robert, it's probably that it's more of a marker for a very high-risk group. The STS, which is the database that Dr. Devlin and I used to execute this study, doesn't allow us to dissect out physiology nor intent. So we therefore can't say much about the conditions that led directly to ECMO preoperatively, nor about the decision making that led to the sequence. So, if you look at other papers in the literature, preoperative ECMO is certainly one of the highest risk factors for death. And this has also been noted in terms of biventricular patients, which this present study had a lot of patients with complete AV septal defect, arches, and VSDs. And ECMO, as a preamble to a biventricular repair or post-biventricular repair, really is a really terrible thing. So my sense is that it's just a marker for either terrible anatomy, a salvage operation that didn't go well, or a patient that really has just so much adverse physiology that they required ECMO preoperatively.
I see. That's kind of what I was thinking, but that's great to hear. Thank you. I know this wasn't really the goal of your paper at all, but I found it interesting that there was a small group of patients who got banded for the treatment of cardiomyopathy. And I have to be honest that despite having always worked in centers that have large transplant programs, lots of cardiomyopathy, I work with Jacqueline Lamore and Neha Bansal, two big-time cardiomyopathy experts, and of course Raghav Murthy, our surgeon who's the surgical head of transplant. I've really never seen that done before, and I'm wondering if you could just explain for the audience, what is the theory of this intervention? And I apologize for the stupidity of this question, but are there data supporting its use?
Yeah. No, it's a good question. It's not very frequent that we do it. Actually, Iki Adachi and his group had a prospective study that they were enrolling patients. We only had 12 patients in our whole series and the whole STS. The theory is very much the same as CCTGA with the systemic RV, and you really are trying to move that septal position and change the configuration of the RV. And so in similar fashion, the theory behind this is that you've got a shift in the interventricular septum back to the left by forcing this sort of apple-like LV shape into a more typical pear shape. So it really is akin to restoring a more favorable ventricular interactions. And I think that they think that this, restoration of septal position can perhaps improve your sort of electrical and mechanical coupling, increase your, EF, and decrease your left atrial pressure. So I think that's the theory behind it. To be honest, I think that the data is relatively encouraging, but I don't think that we have enough numbers to definitively say you've got a dilated cardiomyopathy. This is really what you should do. I think most people, when faced with that, are really thinking, do I deploy a mechanical circulatory assist? Do I keep the patient, on some inotropes and eke them along, and then eventually transplant them if necessary?
Yeah, definitely room for us to learn more about this intervention. So for those in the audience, don't go out and do that just yet. Well, we'll see. I'm going to ask you now, Dr. Karamlou, probably the most controversial question that I have today, which is, the STS has assigned a stat classification of 4 to pulmonary artery bands, which suggests a fairly high-risk procedure, and I think very few people would disagree with that, and your work certainly highlights why it's a stat category 4, not a lot of morbidity and mortality. However, your work showed that for some indications, mortality actually was fairly low with the pulmonary band, but in others, it was exceptionally high. And I was wondering, as somebody who's very, very active in STS, do you think that STS maybe should reclassify pulmonary artery band, perhaps a lower stat category for some interventions, and maybe even a higher stat category, like stat category 5 for others?
Yeah. I think this is, as you say, a challenging but really important question. And again, with most challenging questions, there's no easy answer to it. I think it is somewhat vexing because if you think about surgeon complexity, PA banding conceptually is relatively simple. But as we've discussed, it's really the physiology rather and the associated comorbidities, anatomic complexity that makes the perioperative course complicated. And a major limitation in risk stratification in the STS is that it is a procedurally based categorization and not diagnosis based. You can include diagnoses, as we did in this paper, as covariables, but the episode of care is based on the index procedure. And this is super problematic for PA banding because it is applied to a very heterogeneous group of patients with many diagnoses, from tricuspid atresia, DILV, to, as we talked about, cardiomyopathy, to HLHS, to, people with arches and VSDs and complete AVSDs with, arches, or, someone who comes in with RSV and, an intracranial hemorrhage who can't get a complete repair. So it's challenging. I think, the stat categorization, which most people conflate complexity from a surgical standpoint and risk of death. So the stat categorization strictly deals with the estimated risk of mortality. And as you pointed out, when you have a wide variation in mortality from 8% to 16%, 2% to 30%, it really is the event rate and the higher mortality that really impacts the risk model. I think that my sense is that if we could more granularly include diagnosis, physiology, and anatomy in the STS, for sure, we would be able to say, for example, my scenario would be if you have a patient that has high PVR, a patient who's got the potential for worsening AV valve insufficiency in AVSD, for example, with the application for a band, that might influence your stat categorization. And moreover, center preference is also another critical aspect. Where you are doing the operation plays into the risk of death. So what's a stat 4 in one center may or may not be a stat 4 in the other center. And, aggregated data, while somewhat sensitive to case mix, is obviously not completely able to account for this, I would say, with real high fidelity. So long-winded answer, but yes, it would be great to reclassify appropriately, but we would have to use a more granular database.
Yeah, very interesting, and I never really thought about how STS is procedurally based versus patient diagnosis based. It's a very, very important point that you raised. So thank you very much, Dr. Karamlou. Well, for those in the audience, it's late in the day on Wednesday before release of this podcast. So I'm going to wrap this up with Dr. Karamlou with one last question. As I was reading it, I was thinking that given the high risk of death you've shown to be the case in some of the patient subsets, most notably complete AV canal patients or those who have a VSD with an arch obstruction, they had mortalities in the 16% range, substantially higher than the overall average. I'm wondering, do the data in your work suggest to you as a cardiovascular surgeon that maybe different surgical approaches other than banding should be pursued in those diagnoses? Generally speaking, like for example, we usually will consider a band in an AV canal patient because it's very difficult to get a good result in a very small infant with an AV canal. But should surgeons be trying to come up with novel approaches to repairing things like small AV canal patients, or should we always be trying to fix the VSD and the arch even in that small patient where it might be technically easier to band such a patient and just fix the arch, for example, or stent the ductus or something like that?
Yeah, and I think this is a good one to close with because it really is in some ways, what is the horizon for these patients? One option, avoiding it altogether with primary complete repair. The problem with this is that I think such sort of, statements may minimize the importance of center and surgeon experience in managing these patients. And if you look back at the STS study that looked at, for example, a more simple lesion like tetralogy of Fallot, but that center looked at primary complete repair in a neonate for TET versus BT shunting. And the primary driver for success was center volume of neonatal tetralogy repairs and, in fact, complex neonatal surgery, and the commitment of that center to a strategy of complete repair. So certainly, I think it would be important for us to, if your center has that commitment and that capability, primary complete repair, I think, is a preferred strategy. Now, to your point about innovation, I would say for bilateral PA bands, we now have the ability to use catheter-deployed flow occluders in the bilateral branch PAs. And this may supersede banding as a less invasive and maybe a better physiologically calibrated result. So I think that's important. But the final statement I would make is that in our study, the timing of banding salvage was far worse than planned banding. So getting it right the first time was critical. So if you have to adjust the band, if you really have to, you don't really understand the physiology at that time and you have to make adjustments downstream, those patients had a 16% risk of death versus an 8% risk of death, so double. So I think you got to get it right, look closely at your center, and then sure, let's look at some alternatives that may be better than surgical PA banding.
Yeah, I really thought that was interesting, the aspect in your paper showing that if you had to adjust the band, and on average, those patients did quite a bit worse. And I think it pointed to me, as I read it, the difficulty of pulmonary artery banding, which, seems like it would be a relatively straightforward and easy operation. But I think with changing physiology, oftentimes you're asked to do the band when the PVR is a certain level, and then later it's different. And I think it is a woefully underestimated, challenging operation. I understand the technical aspects may be not that hard, although I'm sure I would have quite a lot of difficulty doing it. But for a qualified surgeon, I'm sure it's not amongst the hardest operations from a technical perspective. But I do think that your work very nicely highlights how challenging it is to get a good outcome using a band, and I think for all of the various reasons that you've explained this evening. Well, Dr. Karamlou, I can't thank you enough for joining us. Thank you for having the bravery to come back on the podcast a second time and share some important STS information with us once more. It's a great pleasure to have you, and congratulations to you, Dr. Devlin, and all of the co-investigators who wrote this very important paper.
Oh, you're very welcome. It's always a pleasure. And as long as you keep lobbing softballs at me, I'll keep coming back.
Thank you so very much. Well, I think you'll agree with me that Dr. Karamlou once again has proven an uncommonly clear visitor to the podcast, offering us a lot of insight into the results we've discussed this week. I thought her important explanation about the STS dataset being procedurally based and not patient diagnosis based to be a critical one, as it helps inform our own understanding of what these sorts of data analyses can and cannot tell us about questions we have about congenital heart surgery. I also found her comments about being careful in regards to making recommendations to surgeons based on these outcomes that they ought to take on very complex or difficult repairs because a PA band may not be associated with a great outcome. In the end, each center needs to understand its own abilities, skills, strengths, and tailor its approach to those. And her example of tetralogy and the ongoing debate of primary versus two-stage repair for this was a great example. And for those of you who may wish to learn more about that debate and what the data suggest in this regard, I'd strongly recommend you take a listen way back to episode number 86 with Professor Laura Mercer-Rosa of Children's Hospital Philadelphia, when she joined us on the podcast to explain this very issue. I'm hopeful that all who have had a chance to listen to this week's podcast have a better understanding of just why this seemingly easy procedure, the PA band, is associated with so much mortality, and how risk of procedures is not only due to the technical demands of a procedure, but also, and very importantly, the substrate in which that procedure is performed. I'd like to thank Dr. Karamlou once more for taking the time from her busy schedule to speak with us this week about this important topic. This past week, the world of opera lost a wonderful singer when the great Polish coloratura contralto Ewa Podleś died of lung cancer. Ms. Podlish was a generationally great singer who had an extraordinary range, from the lowest notes that even some men could be challenged to sing, to high notes that sopranos would be proud of. She was most noted for her work in Rossini and Handel, but today we hear her in a live early 1990s performance of the devilishly difficult aria from Gluck's Orfe entitled Amor vien randra. This is truly unbelievable singing, and the audience knew it, as you'll hear the audience start applauding for her bravura singing before the piece was even over, something that's a rare occurrence in the opera world, but certainly one well-deserved by this great Polish contralto. Thank you for joining us for this episode, and thanks so much to my guest. I hope everyone has a wonderful week ahead.